This is the 9th in a series of presentations on radiography of joint disorders in veterinary patients. This presentation discusses a few remaining miscellaneous but important disorders you might encounter in your practice. In this presentation, we'll describe and provide examples of immune-mediated polyarthropathy, septic arthritis, and joint-related neoplasia. By the end of the presentation, you should be able to distinguish between non-erosive and erosive forms of immune-mediated polyarthropathy. You should be able to describe and identify radiographic abnormalities in septic arthritis and joint-related neoplasia. And you should be able to develop a rank-ordered differential list given the radiographic abnormalities and case presentation. The term polyarthropathy is a nonspecific term indicating that more than one joint is involved. If only one joint is involved, we can use the term monoarthropathy. And certainly in some of our prior discussions, we have learned about developmental and degenerative joint disease that can involve more than one joint. But when we do have multiple joints affected, an additional differential should be immune-mediated polyarthropathy. And there are both non-erosive and erosive forms, and there will be some radiographic findings that might help us distinguish between the immune-mediated arthropathies and the degenerative or developmental arthropathies. So let's start with immune-mediated polyarthropathy in its non-erosive form. You may also hear people refer to this as IMPA, which is immune-mediated polyarthropathy for short. This is an inflammatory condition that is secondary to antigen and antibody complex deposition within the synovium. Of our species, the dog is the most affected, and typically it will affect the medium and large breeds. Multiple joints are affected, and especially the more proximal joints such as the carpus, the tarsus, and the stifle. There are obviously going to be underlying etiologies that are leading to this antigen-antibody complex formation before it is deposited in the synovium. And this slide lists different etiologies to consider. The most common is type 1 or the idiopathic form of the non-erosive immune-mediated polyarthropathy. And if you hear people talk about that patient has IMPA, they probably are referring to the idiopathic form. The next most common is that patients can develop this secondary to systemic infections such as our tick-borne diseases. Less commonly, they might develop IMPA, the non-erosive form, secondary to hepatic or GI disease, or as a paraneoplastic syndrome, secondary to distant neoplasia. And then some patients will actually have systemic lupus erythematosus, which does have immune-mediated polyarthropathy as part of the process. There are some additional breed-specific non-erosive immune-mediated polyarthropathies that I don't have listed on this slide. This slide talks about the radiographic findings in the non-erosive form, which are not very many, because really all we can typically identify in radiographs is the intracapsular soft tissue swelling, and hopefully we'll be able to see that it's in multiple joints. Because it is the non-erosive form, there really are no osseous changes that we're going to identify on the radiographs. In some patients that maybe have poorly managed non-erosive forms, ultimately, chronically, they might develop some secondary osteoarthritis, and it won't look any different than the degenerative joint disease findings that we've talked about previously. In this stifle here of this patient, we can see that there is moderate intracapsular soft tissue swelling of the stifle with absolutely no other findings of any osseous changes. This is that same patient, and this was a Labrador that presented for pelvic lameness and a clinical suspicion of cranial cruciate ligament disease. We've already seen the magnified view of the stifle, and again, we see intracapsular soft tissue swelling with no other abnormalities of the bones. This patient, though, had the TPLO view, which was the view that included a stifle and the tarsus. And because you guys are learning to be systematic, you're not going to stop just looking at the stifle, especially when all we see is swelling and don't see any other signs that are suggestive of cranial cruciate ligament instability. And when we look at the tarsus of this patient, and here is a magnified view, there is moderate intracapsular soft tissue swelling of the tarsocrural joint. So now this patient has two joints that are swollen with no other osseous changes. And this patient was ultimately diagnosed with idiopathic non-erosive immune-mediated polyarthropathy. This is a different patient that has orthogonal views of the carpus through the metacarpus here. And this patient also has multiple joints that have intracapsular soft tissue swelling. In the right carpus and the left carpus, I see that there is fairly diffuse soft tissue swelling centered on all of the carpal joints. So just in the carpus, we have multiple joints that are swollen, and it is a bilateral finding. All of the bones of the carpus are normal. I don't see any osseous changes. Being systematic, we look beyond just the carpus, and there are actual soft tissue swellings involving the second and the fifth metacarpal phalangeal joints on the right and the fifth metacarpal phalangeal joint on the left. So this patient has multiple joints that are swollen, and this patient was diagnosed with non-erosive immune-mediated polyarthropathy secondary to Lyme disease. And this is our last patient that has orthogonal views of the left manus and the left tarsus. This patient is a little bit different breed, and so all of the soft tissues are a bit thicker than we are used to looking at. However, I do see more focal soft tissue swelling that is centered at all of the carpal joints and probably at this metacarpal phalangeal joint down here on the fifth, maybe even the second. And then in the left tarsus, there is mild intracapsular soft tissue swelling of the tarsocrural joint. And this patient, again, has multiple joints that have soft tissue swellings, no osseous changes, and this patient was diagnosed with idiopathic immune-mediated polyarthropathy. So, of course, these patients, once we've diagnosed radiographically that we have multiple joint swellings without osseous changes, are going to need to go on and have further workup, which is going to include joint taps to look at cytology, and then some blood work to look for some of the underlying causes. Erosive immune-mediated polyarthropathy is a severe progressive process that does now have osseous changes, and these are erosive changes to the bones. And then this process is also accompanied by degeneration of the soft tissues, such as the joint capsule and the ligaments, and so it can be pretty debilitating. This occurs in middle-aged patients that are more commonly dogs, and they are small to medium breeds. Shelties and poodles seem to be overrepresented, but there are forms of erosive immune-mediated polyarthropathy in cats. Again, it's going to involve multiple joints because it's a polyarthropathy, and it is more common in the joints of the distal extremities. There are fewer etiologies underlying erosive immune-mediated polyarthropathy, and the biggest one will be a rheumatoid-like arthritis in our dogs. Greyhounds get a breed-specific polyarthritis that is erosive, and then the cats have a feline non-infectious polyarthritis that has both a periosteal proliferative form as well as an erosive form. This slide lists the radiographic findings that we might identify, and it's important to note that the initial finding in the erosive IMPA is still just the joint and periarticular swelling, and radiographic bone involvement can take several weeks after the onset of clinical signs for us to be able to identify, and then those osseous changes will become more obvious as the disease progresses. The example here is going to demonstrate many of the radiographic findings that we can see in a very advanced case. This patient has quite a bit of soft tissue swelling that is both centered at the carpus and extending beyond, so extracapsular and intracapsular joint swelling. Also has soft tissue swellings involving several of the metacarpal phalangeal joints and the interphalangeal joints. Beyond that, especially up here in the carpus, I'm hoping that you can see that there are multiple bones here of the carpal bones and the proximal metacarpal bones where there are articular and subchondral erosions and cystic lucencies. And these can actually extend into the radius and the ulna. This patient also has these kind of articular erosions and subchondral cystic lucencies in the distal aspects of the metacarpal bones and probably affecting at least this proximal phalanx. So these are the advanced erosive findings that we can see. And then as the cartilage becomes eroded and the bone becomes eroded, the joint spaces typically narrow and collapse. And then sometimes these bones will actually look crushed to almost absent due to this kind of collapse. And then because there's also soft tissue damage that goes along with it, we can see subluxations and luxations of the affected joints. Down here in this distal interphalangeal joint of the second digit, there is a subluxation. And then looking at the carpus relative to the metacarpus, notice the metacarpus is actually laterally deviated. So this patient has actually developed carpal valgus because of laxity of the soft tissues. This patient doesn't really have too many changes on this view, but we can sometimes see periarticular osteophytes of degenerative disease and sometimes periosteo reactions that are probably from enthesopathy at the attachments of the joint capsules. This is the same patient DP view, but this slide also includes the lateral view. And on the lateral view, I think we can see that there is marked swelling that is extracapsular and intercapsular on all of those carpal joints. Now I think we can also see some changes in the distal radius. Some of them are kind of subchondral cystic lucencies, but some of it is even a little bit of periosteo reaction, some sclerosis, and some coarse trabeculation. The distal ulna, accessory carpal bone, are additional bones that we can see with changes that weren't as apparent on the DP view. Otherwise, we've talked about all of these findings. This is the same patient as on the previous slide. The stifle of this patient is also very severely affected. There are several kind of periarticular and subchondral areas of erosion in the distal femur as well as in the proximal tibia. This patient has quite a bit of soft tissue swelling kind of centered on this stifle joint. And then this patient has laxity, instability of the medial aspect of the stifle, and there's actually subluxation of that joint. Because this patient has multiple joints involved, one of our differentials definitely has to be this erosive immune-mediated polyarthropathy, and this was an appropriate breed that we would think of getting this disease. But again, we're going to have some further workup. This is a different patient that has very early in the process of the erosive immune-mediated polyarthropathy. So we have orthogonal views of the carpus, and the main finding I see is that there is moderate intercapsular soft tissue swelling of all of the carpal joints, and a little bit of intercapsular soft tissue swelling probably of this fifth metacarpal phalangeal joint. There's some more swelling here dorsally of either that same metacarpal phalangeal joint or some other metacarpal phalangeal joints. If we look closely, we can see that there are some early subtle lesions of subchondral lucencies, especially in this intermedioradial carpal bone, but also I think in the ulnar carpal bone and some of the distal row of carpal bones. And so these, again, are early onset of radiographic findings in the erosive immune-mediated polyarthropathy. This is a different patient that has both the carpus and the stifle involved. On the carpus, I have orthogonal views. We can see quite a bit of soft tissue swelling. In the distal radius, there are some subchondral lucencies. Some of those lucencies are also within the carpal bones, the proximal and the distal row. This patient also has a little bit of periarticular periosteo reaction. That's probably some enthesopathy. And then even the distal ulna here probably has some erosion. So that's in the carpus, multiple joints there. And then this patient's stifle also has some swelling around this stifle joint, and then subchondral erosions affecting the femoral trochlea and femoral condyle. So again, multiple joints involved, most consistent with erosive immune-mediated polyarthropathy. That also takes us to a discussion of septic arthritis, because septic arthritis can begin to look like an erosive form of immune-mediated polyarthropathy. Septic arthritis can involve multiple joints as a result of bacteremia that can be associated with an isolated focus of infection, and that infection may be in the umbilicus, in the respiratory tract, or in the GI. And then that can spread either directly to the synovium or, as we learned about in osteomyelitis, hematogenous spread of bacteremia may like to go to the physis or the epiphysis, and then from there it can actually spread into the joint space. With the hematogenous route of infection, the neonates of the horse and the cow are the most commonly affected, but immunocompromised individuals who are older can also be affected. As I said, the horse and the cow are the more common species that we will identify septic arthritis, but the dog and the cat can also have septic arthritis. We can have one joint involved or monoarticular septic arthritis, and that most likely results from direct puncture, joint trauma, or extension from regional soft tissue infection. And so when it is just one joint, it could certainly be in any age or any species. In small animals, septic arthritis is much less common than immune-mediated arthropathy. However, more and more septic arthritis can be identified in joints that already have pretty significant degenerative joint disease. And so if you have a patient that comes in with very acute lameness and pain in a joint that you already have been controlling for that pain, we might want to suspect septic arthritis and do a joint tap to assess the cytology. When it does affect the joint like this, it's oftentimes the more proximal joints that have chronic DJD that get set up for septic arthritis. This slide lists the radiographic findings of early septic arthritis. And when we have early findings, it can be difficult to diagnose radiographically because the most important early finding in septic arthritis really is just joint swelling. We may have both intracapsular and periarticular extracapsular soft tissue swelling. These are orthogonal views in a calf that has septic arthritis, and we can see that the predominant finding is of this diffuse joint swelling affecting the carpus. Sometimes in these patients, the joint space can actually look wide, and that's because there's so much fluid in the joint and can kind of distend some of the joint. If we're lucky, we might identify intracapsular gas that could be secondary to a gas-producing bacterial infection or if there was a puncture wound. And in this patient, there are actually several small bubbles of gas opacity that are within the joint. And so that would help us to distinguish this as septic arthritis. However, again, it can be difficult and challenging to differentiate this from other causes of joint swelling. But this is when we want to identify septic arthritis because we want to treat it before the osseous changes. Now, when septic arthritis becomes advanced, then we're going to start to see osseous changes that will be very erosive and can look similar to the erosive form of immune-mediated polyarthropathy. This is the DP view of that calf that had on the previous slide the early changes with septic arthritis. And this is the calf a few weeks later that has much more significant advanced changes of the carpal bones now having erosive or lytic lesions in multiple sites of multiple bones, even some lysis up here in the epiphysis of the radius, and then even more of a focal area of lysis here in the proximal fused third and fourth metacarpal bone. So all of these findings are going to be highly suggestive of septic arthritis that's pretty advanced. Again, we might still see the swelling, joint space widening, and now the widening is caused by that lysis of the carpal bones, and you can compare those to the patient previously. Here's an example of a calf that has hematogenous spread of infection that actually went likely to the physis first. So we have a DP view of the kind of fetlock and a lateral view. We can see areas of lysis associated with the physis and areas of lysis extending into the epiphysis, quite a bit of soft tissue swelling. And then there is, although harder to see, there is soft tissue swelling that has affected the metacarpal phalangeal joints here. And so this patient had extension from the lesion that was infected in the physis epiphysis down into the synovium. So septic arthritis, epiphysitis, and physitis. Here's an example of a foal that has very early changes of septic arthritis, but also has some changes in the epiphysis of the tibia. This patient in lateral view has pretty significant intracapsular soft tissue swelling of the tarsocrural and proximal intertarsal joint. And the bones look pretty normal for this age. This is a very young patient. On the DP view, we see that soft tissue swelling. The only additional finding is that there is some multifocal lysis of the medial aspect of the distal tibial epiphysis. And so this patient has septic arthritis and septic epiphysitis. And this was determined to be hematogenous, and this patient had other joints involved as well. This is an adult horse, and this horse had a puncture wound several weeks prior to these radiographs. And on our orthogonal views, we can see very significant soft tissue swelling that's extending over all of the tarsal joints. So some of this is very focal and probably of the tarsocrural and down into the distal tarsal joints, but also extending beyond the joint capsule. So we have extensive extracapsular swelling. When we look at this patient closely, we can see that in the tarsometatarsal joint, there are these subchondral erosions and the articular erosions. Although we talked about being able to see those in degenerative joint disease of the tarsus, this patient has all this significant swelling. And additionally, if you look, the joint space is quite wide instead of being narrowed as we saw with degenerative joint disease. And so these findings altogether should make us think that there is actually an infectious process going on. And so this patient has advanced septic arthritis, predominantly osseous form affecting in that tarsometatarsal joint, but I wouldn't be surprised if other of the joints also were infected. Here's an example of a cat that is an older cat that was immunocompromised because it was on immunosuppressive doses of prednisone. And this patient became septic and had the hematogenous spread to multiple joints. And this just is one of the carpi. In this patient, there's quite a bit of soft tissue swelling, and then if we look at almost all of the bones of the carpus, including the distal radius and ulna and the proximal metacarpal bones, there are quite a bit of articular erosions, lysis, and subchondral erosions. This patient also has fragmented some of these bones pathologically, so there are all these multiple bone fragments. In our older dogs and cats, it can be difficult to distinguish our joint infection from the erosive form of immune-mediated polyarthropathy. So obviously we need to do additional diagnostics just like we would for any of our other arthropathies. We're going to finish out this presentation with a brief discussion of joint-related neoplasia, and we have touched on this in our discussion earlier on kind of tumors affecting bone. When we are talking specifically about joint-related neoplasia, synovial cell sarcoma is the one tumor of the joint, but it is an uncommon malignant tumor. It is of the synovial tissue, and unlike the other disorders that we've talked about, this is going to be monarticular. It will only affect one joint. The stifle is the most commonly affected joint, followed by the elbow, and then other joints can also be affected. The joint-related synovial cell sarcoma occurs most commonly in middle to older age dogs and more commonly in medium to large breed dogs. Again, it is one joint affecting one joint. Other joint-related soft tissue tumors can occur nearby and potentially involve the joint, and those include histiocytic sarcoma, fibrosarcoma, and undifferentiated sarcomas. And there really aren't going to be any specific radiographic findings that can help us be histopathologically correct in our diagnosis, so we're going to not be able to get too specific. We're just going to see findings that suggest that it's a joint-related neoplasia. So our radiographic findings will include, especially if it's advanced, multiple things that we can assess for. And so certainly we're going to have quite a bit of mass-like soft tissue swelling typically identified when we have a joint-related neoplasia. These are orthogonal views of a stifle of a dog. This dog has previously had an extracapsular repair of its cruciate ligament, and so that's what this little discrete lucency is in the tibial tuberosity. But this patient has quite a bit of extensive soft tissue swelling that is irregular and mass-like. And then if we look at all of the bones of this joint, we have multifocal areas of lysis affecting many bones. So these are kind of geographic, discrete areas of lysis in the distal femur, distal patella, the fibula, and the proximal tibia, as well as in the proximal fibula. So in this patient, they're more non-aggressive types of lysis, but we can also see moth-eaten lysis. And notice that all of these areas of lysis are kind of in the outside of the joint region, so our periarticular regions, where I might expect that synovial joint capsule to attach. And this is different from when we saw our erosive form of polyarthropathy or septic arthritis, where those were happening predominantly on the articular surfaces. And then we may see some aggressive periosteal reaction, so we could see some spiculated reaction, sometimes more benign or non-aggressive reactions as well. So this is a patient that has a synovial cell sarcoma affecting this stifle. Here's a patient that has a synovial cell sarcoma that is affecting the carpus. The carpus has pretty irregular and pretty marked soft tissue swelling that is more mass-like along the dorsal and palmar aspect, a little bit more here on the medial aspect. And then when we look closely at the bones, we can see that at the outer margins of many of these bones, the distal ulna, the distal radius, both cranially and caudally, and several of these carpal bones, and even potentially this metacarpal bone, are kind of areas of geographic to areas of moth-eaten lysis. On the DP view, we can see some more of these kind of geographic to moth-eaten areas of lysis. And although they are affecting some of the carpal bones, they're still kind of out in the periphery where the joint capsule is probably attaching. And so this is again distinguished if you go back from what the erosive form of polyarthropathy and what the septic arthritis looks like. Here's a patient that has a different type of tumor. This is a histiocytic sarcoma that is surrounding and affecting the stifle joint. This patient had previous stifle surgery. This is a K-wire, probably from a tibial tuberosity transposition. But currently what we see is that there is quite a bit of mass-like soft tissue swelling surrounding the entirety of this stifle joint. Here it looks very focal at the medial aspect as well. And then when we look at the bones, at the periphery of the femoral trochlea, the patella, the femoral condyle, and the proximal tibia are areas of moth-eaten lysis. Here on the craniocaudal view, we can actually see some lysis that's what is affecting the trochlear ridge right here. And so multiple bones have lysis, so this is not a primary bone tumor, right? Because there's some lysis of the tibia, and then there's like this mass like soft tissue swelling. And then in this patient, an additional thing that you might identify and be able to sample is that this is a massive enlargement of the popliteal lymph node. This is big enough that we'd be concerned that this would be metastasis. Be sure to look in the textbooks, in the chapters, and in the index to look for additional information regarding the disorders that we talked about and some additional examples.